everybody, this is Dr. Barry, and in this lecture we're going to talk about health insurance, which is from chapters 15 and 16 of the Rada McNamara text. In this lecture I'll be jumping around a little bit from the text. I'm trying to go in what to me is the most logical direction through all this information. And there is quite a bit here, so you might want to plan to watch the video a couple times. When most people think about health insurance, they're thinking about medical expense plans, or the type of health insurance that covers medical bills, surgeries, and outpatient visits to the doctor's office. But health insurance also includes disability insurance and long-term care. So we'll talk about all three of these in this lecture, but we'll spend most of our time on medical expense plans. We'll start with a discussion of group medical expense insurance financing. In other words, who are the types of companies that insure medical expense insurance? And they are commercial insurers, Blue Cross Blue Shield, managed care plans, and self-insured plans. And there's actually quite a bit of overlap between these four different ways of financing healthcare. Blue Cross Blue Shield is often now a for-profit insurer in some states. Most states have their own Blue Cross Blue Shield, which is not affiliated with other states' Blue Cross Blue Shields. It operates much like a commercial health insurer, and I won't spend a lot of time describing a commercial health insurer because you're aware of those organizations from our discussion of types of insurers. Additionally, when we talk about managed care plans, most plans today have an element of managed care, whether it's a commercial insurer, Blue Cross Blue Shield, or self-insured plans. But there are plans that were formed specifically and initially as managed care plans, such as Kaiser Permanente plans and WellCare. These are HMOs, and we'll talk about HMOs and PPOs in just a moment. And then another big area of medical expense financing is now self-insured plans, where employers decide to self-insure all or part of the benefits provided to their employees. This can be very good when an employer is large and has the ability to predict losses much like an insurance company would. Usually they'll use a third-party administrator to actually handle the claims and to implement any kind of managed care, and they'll usually have a stop-loss, sometimes called reinsurance coverage in force as well. So now let's look at the different types of group plans offered. And group insurance is almost always preferable over individual insurance, even after the Affordable Care Act, which has made individual insurance a little more like group insurance in that individuals can now come to market as a group when they go through the insurance exchanges. Still, group is going to tend to be a little less expensive, but that might change over time if the insurance exchanges have success. So there's health maintenance organizations, or HMOs, preferred provider organizations, or PPOs, and then there's also a relatively new area that's picked up popularity in recent years called the Consumer Directed Health Plan, or CDHCs. Let's start with a look at HMOs. With an HMO, the insured is going to have a network of providers that they're allowed to use. In other words, insureds within the HMO are only allowed to use providers, doctors, and specialists and nurses that are part of the HMO network. At least that's so in its traditional form, and the insured get zero for out-of-network providers unless it's an emergency. Over time, this has changed a bit where some traditional HMOs have actually backed off of this and now allow insureds to use non-network providers, but they have to pay a significant copay. Now it looks more like a preferred provider organization. With health maintenance organizations, providers usually have significant financial incentives to keep patients well, or at least that was the idea when health maintenance organizations were established. The point is that providers usually have caps on how much they can make, and because they have negotiated charges, for example, for a treatment or a surgery, they have an incentive not to go over in cost. There is a heavy emphasis on managed care with health maintenance organizations, and I'll talk more about that now. Examples of managed care are prior approval, which means that before you get a certain treatment, such as maybe a tonsillectomy, you have to get prior approval from the HMO for that procedure. There's also utilization review or case management. So this is where the insurance company or the HMO reviews your treatment protocol over time. So for example, if you've had to have knee surgery, then the insurer is actually reviewing that treatment and making sure that you're not receiving too much care, staying in the hospital too long, etc., and that you're getting sufficient care, which is sometimes controversial because physicians who are actually providing that care will tend to say that they know better how much care you need than the insurance company. Also, with managed care, you typically have a gatekeeper. Usually a gatekeeper is your primary care physician. For women, it's sometimes your gynecologist. And in order to go to any kind of specialist, such as an ear, nose, and throat specialist or an orthopedic surgeon or a neurologist, you would have to go through your primary care physician who would then refer you to the specialist. Now let's talk about a preferred provider organization, or PPO, which also has a significant amount of managed care. A PPO also has a network of providers. With the PPO, you get a lower percentage if you go out of network, so where if you use an in-network provider, you might pay only 20%. If you go out of network, you might pay as high as 80%. The numbers of PPOs are growing dramatically. They are a bit less extreme and more flexible than the health maintenance organization, but they have the managed care benefits that traditional health insurance doesn't have, which we're not even going to talk about traditional health insurance today because it's basically non-existent. And as I've already said, PPOs also have significant managed care components. And by the way, I should add that Blue Cross Blue Shield, though they were mentioned separate from both commercial insurers and managed care organizations, they actually have embraced the HMO and PPO approach significantly, and in fact in many states have the majority of the market share with their HMO or PPO in that state. Now let's look at consumer-directed health plans. These are very high deductible insurance plans combined with either an HSA or HRA. Let's look first at an HSA. HSA, or Health Savings Account, is used with a high deductible health insurance plan. And it's actually a government-established program where for 2015, the annual deductible of the plan must be at least $1,300 for the individual and $2,600 for a family. And then there's the savings account. For 2015, the maximum contribution is $3,350 for an individual and $6,650 for a family. The HSA contributions are tax deductible up to those contribution limits, and investment earnings accrue tax-free. So essentially, the insured is setting aside money in a tax-free vehicle that's similar in its operation to an IRA that will pay for any medical expenses that are used until the health insurance plan deductible is met. The only problem with these types of plans is if an individual doesn't have enough money in a savings account to pay for those medical expenses they incur before they reach the deductible. But these can be very good alternatives to other forms of health insurance. And also, they cannot be used for anything other than medical expenses without being taxed on the investment earnings and without getting a penalty until the individual reaches age 65. The health reimbursement account reimburses employees for medical expenses not covered by the employer's health insurance plan. It's funded 100% by the employer, and employers can take a tax deduction for the amounts that they have contributed. So in other words, there would be a corresponding employer plan. This is just a supplemental plan that helps pay for those expenses, which can be very high at times, that are not covered by the employer plan. Now I want to discuss some important considerations that you should have when selecting a health plan. Nearly everyone is faced with the decision of which health plan to choose when they start a new job, or oftentimes even with the same employer, sometimes as much as once every year. One consideration is coverage for drugs. If there's a particular drug that you or a family member that's under the plan takes every month, or drugs, then you would want to check how much the plan will actually pick up in terms of the cost. Also, whether or not the plan will pay for the brand name drug if you prefer or are required to take the brand name instead of the generic drug. Sometimes your physician can request that you take the brand name instead of the generic, and the plan will pay a larger amount for the brand name. Some plans won't cover brand names at all. unless the physician requires it. In general, your out-of-pocket costs for generic drugs are going to be much less than the brand name drugs. But since this is such a significant expense for so many of us, it's often very important to check this before selecting a health plan. Next, choice of physicians. As we just discussed, many health plans have a network of physicians. So if there's a general practitioner that you prefer to use, you would want to check and make certain that they're covered under the plan. Additionally, if there are specialists that you prefer, such as a heart specialist or an ear, nose, and throat specialist, or just any specialist that you regularly see, you would want to check and make sure that they're also covered under the plan. Next, cost sharing. There are 3 ways, primarily, that health insurance requires the insured to share in the cost of their own health care. There's a 4th way that we'll discuss in a moment, but the first 3 are deductibles, co-payments, and coinsurance. A deductible in health insurance works a little bit differently than a deductible in most property insurance. Deductibles are usually annual, so usually at January 1st every year you have to begin to meet the deductible again before the health insurer will pick up any of the cost. These can range from $500 to several $1,000s, especially if you have a consumer-driven plan. Co-payments are flat amounts, usually $20 to $50 for every ailment that you pay per physician. So for example, if you had a broken arm and you went to see your general practitioner, you might pay him or her your $30 copay. Often these are higher for specialists. So when you go to see an orthopedic doctor, you might then be required to pay $40 to the orthopedic surgeon. But you shouldn't have to pay this again for follow-up visits. And this is something that you might have to check with the physician or the physician's office manager or whoever handles the insurance. Coinsurance is a percentage sharing of the cost on every dollar spent on healthcare. So for example, the coinsurance percentage might be 80%. This would mean the insurer pays 80% and the insured pays 20%. Frequently, in particular with the PPO type of health plan, the insurer pays more for in-network providers and less for out-of-network providers. So for example, when you use an in-network provider, you might get 80%, but 75% or even as low as 50% or less for an out-of-network provider. And these days there are even tiers of providers within some managed care plans. Next is usual, customary, and reasonable charges. This is actually another way that insureds under health plans share in the cost of health care. Often the insurer will only pay the usual, customary, and reasonable charges for that particular region. Health plans have codes for different charges that are usual, customary, and reasonable for particular procedures and other types of medical care. So if the physician that you use charges a higher amount than the UCR for the region where you're receiving the treatment, the health plan would only pay the UCR and you'd be left paying the rest. We'll look at an example of all of these: deductibles, co-payments, coinsurance, and UCR in a moment. And the last thing to consider is the premium. Oftentimes, people put too much emphasis on the premium when making a health plan choice and don't realize that the premium might be less for one plan than another, but the cost sharing might be much higher. So ultimately, you end up spending more out of pocket for cost sharing and usual, customary, and reasonable payments than you would with a plan that has a higher premium. Now let's look at an example. Let's say that Angela breaks her arm and goes first to her general practitioner, but then is referred to an orthopedic surgeon who recommends surgery. She has the surgery and then goes back 3 times afterwards. Angela's policy terms are as follows. She has a $1,000 annual deductible, which at this point she hasn't met any of this. She also has a $25 copay for her general practitioner and a $40 copay for a specialist. And she has 80% coinsurance. The orthopedic surgeon and clinic charge $5,500 for this, but the UCR, the usual, customary, and reasonable charge, says the insurer, is $3,500. So let's now look at what Angela has to pay out of pocket for this broken arm. Let's look at Angela's share. First of all, she has to pay a copay, one to the general practitioner and one to the specialist. the total will be $65, $25 to the general practitioner and $40 to the specialist. Remember that the usual, customary, and reasonable was $3,500, but the physician charged $5,500. So Angela would actually have to pay the $2,000 over the UCR. Coinsurance is going to be 20%, which if she had gone out of network, it might be a higher percentage for her. So 20% of the $3,500, the usual, customary, and reasonable charge is $700. And the deductible is $1,000. Note, all covered medical expenses meet the deductible, but those medical expenses that Angela would have paid out of pocket anyway do not meet the deductible. So Angela's total out-of-pocket cost is $3,765, and we didn't even address the general practitioner's charge. She'll pay 20% of whatever the general practitioner charges. So as you can see, the premium might be a small part of how much an individual has to pay out of pocket for health care. Now let's look at some major elements of the Patient Protection and Affordable Care Act of 2010, realizing that this is obviously a very complicated act, and going too far in depth into this act would be beyond the scope of this course, but we'll hit the highlights. First of all, the Affordable Care Act, which is often referred to as Obamacare, has an individual mandate. With a few exceptions, nearly every American is required to purchase health insurance. If they do not purchase health insurance, they are assessed a penalty. This has been a major source of controversy and is still being debated in Congress. The Supreme Court ruled that the individual mandate was constitutional because it is viewed as a tax. Also, essential health benefits coverage are required. This created the controversy where President Obama stated, if you like your health plan, you can keep it. Some health plans did not cover the essential benefits and therefore had to be canceled. The essential benefits include ambulatory patient services, emergency services, hospitalizations, maternity and newborn care, mental health and substance abuse disorder services, including behavioral health treatment, prescription drugs, rehabilitative services and devices, laboratory services, preventive and wellness services, and chronic disease management, pediatric services, including oral and vision care. Many of these are aimed at controlling the cost of health care, keeping Americans healthier so that the overall cost of health care goes down. Take a look at the insight on page 298 of Chapter 15 of the Rada McNamara text, where it shows how much higher the annual expenditure of Americans is in health care compared to most other countries. In the United States, in 2009, the average expenditure was about $7,600, compared to the next highest country, which was Norway, at $5,128. If you compare it to our northern neighbor, Canada, $4,139. All of these OECD countries have some form of government-paid health care, most of them 100%. The next element of the Affordable Care Act are affordable insurance exchanges. This is what I mentioned earlier, where individuals can now go to the exchange and get the benefit of going as a group, hopefully getting lower premiums. Next, premium tax credits to individuals, families, and small employers. Eligibility for the individual and family premium tax credits is limited to U.S. citizens who do not have access to health insurance through an employer's plan. It also is based on income. The small business tax credits began in 2010 but were increased in 2014. Beginning in 2014, the tax credit for small employers with fewer than 25 full-time equivalent employees is 50% of the employer's contribution if the employer contributes at least 50% of the total premium costs. Next is the expansion of Medicaid. The original legislation expanding Medicaid required states to expand their Medicaid programs to cover more uninsured people. However, the Supreme Court struck this provision down, saying it is unconstitutional. Because of this, several states, including the state of Louisiana, chose not to participate in the Medicaid expansion. Now let's turn to a discussion of disability insurance. First of all, disability insurance is a very important type of insurance and often overlooked. This is because the frequency and severity of disability is higher during working years than death. In other words, you are more likely to become disabled, and the cost of disability is higher during individuals' working years from about 22 to 65 than the likelihood and cost of death. Now let's look at the insurance policy itself. First of all, how disability is defined in the policy is very important. Let's look at the definitions of disability from most restrictive, which pays the least often, to the least restrictive, which pays the most often. To be disabled, you must be, the first definition is unable to perform any occupation. This is the most restrictive. Unable to perform any occupation for which you've been reasonably trained, and then unable to perform your current job. This is the least restrictive. In other words, if you can simply not perform your current job, you would qualify to collect under your disability insurance. Let's say that you are a physician who performs surgeries. If you are unable to perform surgeries because of a nervous system problem that's resulted in your hand shaking, you might still be able to see patients, which is an occupation for which you've been reasonably trained, and certainly it is an occupation. Therefore, you wouldn't qualify for disability under the unable to perform any occupation or the unable to perform any occupation for which you've been reasonably trained definitions. There is also partial or residual disability in addition to total disability. Partial is based on how much less you can do. Residual is based on how much less you make. So if, for example, the doctor who now qualifies for disability because he's only able to see patients but not perform surgeries, this might be a 30% reduction in the tasks that he can perform. On the other hand, if the policy pays a residual disability, it would be based on how much less his income is because of his inability to conduct surgeries. Now let's look at long-term care. Long-term care pays a daily or monthly benefit for medical expenses and assistance with daily living, or custodial care. Some long-term care policies pay only for a nursing facility. Others pay for a nursing facility, a hospital, or even at home. Long-term care is a very important type of health insurance because we have an aging population. People are living longer, but not necessarily healthier. So more and more people today spend time in a nursing facility or need assistance at home. The cost of long-term care is between $90,000 and $130,000 or even higher per year. To be eligible for long-term care, you must not be able to perform 2 or 3 of the 5 activities of daily living or be a threat to your own health and safety. The 5 activities of daily living are eating, bathing, transference, which is getting up from a bed to a chair or getting from a chair back to the bed, toileting, and continence. So this ends our discussion of health insurance.